as an epistemology, but rather to reveal that in part it is a cultural creation and to start to interrogate how and why that is. As we write in the critical introduction of our book, we're very interested in thinking about biomedicine as a cultural product. And this is a shared problem for medical practice and for scholars in the humanities. In the introduction, we ask, how are medical ideas about the body constituted, circulated, and settled? Medicine understands itself as a positivist science, and yet it also exists in negotiation with other domains of culture. Language and thought define the limits of the body, from the body's place in the world, to how bodies relate to each other, to what counts as health or illness. As we write in the introduction, the borders of health and illness, like the normal and the pathological, are fragile. New illnesses appear and old illnesses disappear as a result of epistemic shifts and drifts. And we're especially interested in this collection in problems that seem just slightly out of reach of biomedicine's grasp, like disability, bias, exclusion, structural inequality, aging, grief, suffering, and death. These problems that are lived cultural experience as well as biological experiences. Aging, for instance, is both a biomedical reality and a social condition. Sex is a biological act that's tied to cultural ideas of affect, desire, and beauty. So together we were all asking, how are these states of being rooted in our bodies? And at the same time, how are they created in language and culture? And how can we understand what we assume to be natural, transparent, lived experiences of our bodies as products that are created by history, culture, and narrative? Our hope is to encourage our readers to revisit with a fresh eye the cultural norms that govern healthcare and treatment. For example, the pressure towards a cure, which sits uneasily with the lived realities of some people with disabilities. We should say our editorial orientation as literary scholars has shaped the objects of study in our volume. We're particularly alive to how fiction finds powerful forms of expression for changing ways of life. As a whole, our book is treating the points of view of both the clinic and the humanities department as valid in the broader critical examination of biomedicine's cultural influence. And in the end, we adopt the characteristic attitudes of the study of the humanities, like inclusivity, diversity, and intersectionality, among other approaches, as it makes its critique of the frameworks and institutions that govern medicine and the effects of medicine on culture. So Rishi, do you want to turn to some of the takeaways from the book and the contributions that you think it's making to the discourse?
Yeah, I mean, I think, again, it's still, I think, I see it as a deeply kind of emerging field, even though we've been, you could say 20 years or 50 years, depending on kind of where you look. Do you start in the University of Galveston in Texas? Do you kind of move on to narrative medicine? I mean, where do you position the kind of history of this set of disciplines? But I think each kind of person who's coming to it is really coming to it with their own set of kind of concerns and specifications that they're trying to bring to bear on this thought. So, what I see most kind of strongly is just the ways in which our writers have been able to kind of think the social and the literary and the political with the biomedical, kind of holding all of that in a space together is, I think, the kind of real sort of critical aspect to the kind of work that's being done. And also the space that the journal has opened up and that the book has opened up is a space in which I think people have been able to kind of respond to each other's writings, to kind of grow from those and to kind of change one's own approach as well. The other aspect that it's hard to kind of leave away is that the humanities as a field has so much to kind of offer the sort of world of study. And many of our students in particular are trying to find new ways to kind of, I don't even want to call it applied humanities, because I'm not sure that either I dislike or like that word, but I think that the work they do matters, right? That reading well and thinking well, however you understand those concepts, kind of matters to how we shape the world and make a more kind of just present and future. And all of us are sort of in some capacity I think, working toward that. And part of our work is, that's the horizon for, I think, this book and for the medical humanities generally, is a kind of, almost a medical justice. And I think that that's something that we need to keep striving for and working towards.
That's great. I think too, one of the takeaways that we realized as we were putting the book together, and we wrote about it in the introduction, was that although everyone had a distinctive disciplinary approach and a way of doing their research, particular to their field, all of our contributors shared a set of attitudinal values, or borrowing the language of orientations from phenomenology. These are attitudinal orientations that we all had, which actually permeated and transcended the particular disciplinary approaches of each of us. So one was that everyone was very attentive to ethics, and everyone really believes that the medical and health humanities must acknowledge suffering and marginalization and act to alleviate both. And then we think that this discipline has the potential to reimagine existing institutions and practices, and thinking about how they might become more inclusive and just. And we noticed as well that everyone contributing to the volume was attentive to the importance of critique, which is a practice that has a very long tradition in the humanities. It's a method of radical doubt that helps us to identify inadequacies or lacunae, but also to imagine alternatives to the status quo. And so we were thinking, one area where the critical reasoning practices of the humanities might really do good in the world beyond the scope of our book is to use these rigorous approaches to strengthen biomedical progress, for instance, in order to counter science denialism. And then the last attitudinal orientation that we found present in everybody's work was a sensitivity to style, because we notice in our scholarship, in our lives, that too much dedication to jargon and to closed vocabularies can really cut off collaboration. And so what we're especially grateful for from the contributors of the book and from Synapsis writers more generally is that everyone is willing to present their scholarly ideas in very rigorous terms, but using language that's accessible and that can communicate across disciplines, using ordinary language that retains its scholarly rigor. And so one of our hopes with this book is to, by making explicit these attitudinal orientations, we can produce a vision of what the medical and health humanities can do across these different disciplines through collective attitudes that we think are portable beyond the book. So that was one of our great discoveries as we were going through it. Rishi, do you want to say anything more, or should we turn it over to our writers?
I think it'd be great to hear from them. I think it'd be perfect timing.
Great, excellent. So we'll go in the order of the chapters of the book. Each writer will tell us in 5 minutes or less what their chapter is about, and then we will have some Q&A afterwards. So first, I'd love to introduce Olivia Arndal-Woods, who's Assistant Professor of Literature at the University of Illinois at Springfield.
Thank you so much. And thanks, of course, to Arden and Rishi for all their work editing this. So my chapter is called Reproducing Horror, 19th Century Vampires and 21st Century Megasellers. And basically the chapter looks at the question of whether, spoiler alert, the answer is no, whether the kind of horror that stalks the possibility of female and feminine reproductive bodies in 19th century fiction decreases with the improvements in medicine and medical treatment of reproductive bodies over the course of the 20th century and into the 21st century, that of course make the experiences of pregnancy and childbirth much less likely to kill you. But instead of receding, that horror kind of explodes in these two 21st century megasellers that I look at in the chapter. First, the sort of pregnancy and birth scene in the final Twilight book, Breaking Dawn, which if you haven't read the book, maybe you've seen some of those clips from the movie iteration of it. But basically what happens in that novel is that the character becomes, the human character has this vampiric pregnancy that basically eats her from the inside out, and accelerates incredibly quickly and more or less explodes out of her body, necessitating her death and then vampiric rebirth. And then we see a similar like explosion of the dangers of the reproductive body in the final 50 Shades of Grey novel, which is 50 Shades Freed, obviously in part because those novels are based on the Twilight story. But in those novels, and in that final novel, and then in particularly in the film adaptation of the novel, the pregnancy of the heroine in the final novel becomes the kind of drumming threat, or the pregnancy itself isn't the threat, but the pregnancy is what sort of catalyzes the threat. And it starts when she realizes very early in the pregnancy from an ultrasound. She refers again and again and again to the embryo as a blip, a tiny blip. And so there's this sort of emphasis on, in both of these novels, there's an emphasis on the ways that on medicalization. I spoke less about that in the Twilight synopsis, but there's an emphasis on medicalization and the way that medicalization makes these pregnancies visible, hyper visible very early. And that is sort of what allows the danger of the pregnancy to take center stage. And so what I was thinking of as I was sort of collecting my thoughts about this for today was how I wrote this entire chapter before Dobbs. And in fact, I wrote my entire book, Pregnancy in the Victorian Novel, which is coming out from OSUP in November, with the exception of a final round of revisions also before Dobbs. And so the final round of revisions that I was doing this past summer in the wake of Dobbs had a lot to do with bringing that book about Victorian representations of pregnancy into conversation with this present context, which felt unbearably relevant and also unbearably difficult to bring into relevant conversation there. And so, I mean, I think that a couple things I want to think about my chapter in this book in that context as well. I want to really focus on the way that what's happening in these narratives, in these 21st century narratives of the dangers of reproduction, is that reproduction is particularly dangerous insofar as it's particularly accessible to us so soon. And so what happens in Twilight is that the soonness of it becomes the plot of the pregnancy. She finds out she's pregnant, I don't know, like 5 or 6 weeks in, and then within a couple of weeks, maybe a month or two, she's expanded and the baby has started eating her from the inside out, and it's that she's given birth. And similarly, in 50 Shades of Grey, what happens is that very early ultrasound that identifies the blip and then sort of flips the whole script into the danger of pregnancy. And so the note that I kind of want to end on, which is not a part of this chapter, but which would be if I were writing the chapter today, is that these are narratives, as are so many of the narratives available to us about the dangers of pregnancy and the dangers of the reproductive body. These are narratives about the dangers that white women face. And of course, we know before Dobbs that in an American context, in a 21st century American context, the dangers of pregnancy are not primarily faced by white women in America. And we know that that's certain to accelerate and intensify in a post-Dobbs world. So I want to call attention to that and give up my time. Thanks.
Thank you. We'll hear next from Alicia Andrzejewski. Go ahead.
Hi. My remarks are written out because I'm kind of can't think past about 3 or 4. But again, I want to thank Arden and Rishi for starting Synapsis, as well as all of my fellow contributors. It's just a complete honor to be a part of this collection with you. My piece is titled Postpartum Exhaustion in William Shakespeare's The Winter's Tale. And the first play I went to after giving birth to my daughter was The Winter's Tale, and I was about 10 months postpartum. And I remember vividly the scene where Queen Hermione is dragged to court by her husband, King Leontes, a few days postpartum to defend herself against accusations of infidelity. And Kelly Curran, who played Hermione in this production, was brought on stage in a dirty, bloody nightgown by two men struggling to walk, to hold herself upright, eyes wild. Imprisoned on these charges during the late stages of pregnancy, she gives birth to her daughter, Perdita, in a jail cell. Once in court, however, she pleads with her husband against his immodest hatred and laments being denied the childbed privilege, which she argues belongs to women of all fashion. And so the childbed privilege that Hermione describes here is the early modern practice of lying in for about a month, at least a month postpartum. And it was concluded by what's called a churching ceremony to symbolize the new mother's re-entry into the social world. So I had read The Winter's Tale countless times before seeing this production. But 10 months postpartum, Hermione's words felt heavier and they felt different. And so Curran's gestures in the scene transported me back to the sharp sting of trying to walk after giving birth, watching her hobble on stage, hold on to various structures, and breathe heavily while pleading her case reminded me of when, just 2 weeks postpartum, I put on dress pants and a fresh supersized pad between my legs, and I left my husband with our newborn baby to go to a job interview. 2 weeks postpartum. I was just unsure of how I was going to fund the 6th year of my PhD program, and I felt like I didn't have a choice. So I sat in a department's chair, the department chair's office, bleeding in a blazer, poised and eloquent, and I got the job. So go me. But it was this production, this experience that inspired my chapter in this collection, in which I describe how people who have just given birth find themselves, like Hermione, hurried to various places, various institutions before they have fully recovered their strength. I write that we postpartum bodies are exhausted, and I wanted to give voice to this experience shared by people across time, from antiquity to now, in hopes that postpartum people will begin to advocate for themselves and that institutions will listen. And I write that I know I do not speak only for myself when I say my dream is not more doctor's appointments or even quicker healing. I dream of accommodation for people who have just given birth, professionals coming to people's homes, of postpartum labor being distributed fairly among men and women, of people who have not given birth, knowing or caring what postpartum people might need, of postpartum parents feeling more comfortable asking for what they need, and in general, just having these conversations. So in the 5th trimester, a book about returning to work after giving birth, Lauren Smith Brody argues that the most important question a person can ask themselves postpartum is, what do you need right now in a world where it's all about somebody else, right? And then to ask for what you need. And she says that if she had even thought to ask herself that question, then perhaps she wouldn't have spiraled quite as severely postpartum. So as a start to addressing the needs of postpartum people, I argue that we can hear Hermione when Leontes refuses to, as well as the voices of people who are speaking out now, so as to begin to take postpartum exhaustion more seriously. So that's my chapter.
Thank you. And I realize I neglected to introduce you. So you've just heard from Professor Alicia Andrzejewski, who's an assistant professor of English at the College of William and Mary. We will hear next from Christina Flutie, research assistant at the Veterans and Families Institute for Military Social Research at Anglia Ruskin University. And Christina is joining us from the UK, so it's very late at night. Thank you for being here.
Thank you for having me. Thank you for the opportunity to speak at the launch of this exciting new book, which has been a joy to be part of. Congratulations to everyone involved. At the time of writing my chapter, the key project in which I was involved explored the lived experience of families coping with limb loss. The research contributed to improving understanding within the charitable and health sectors of how families live and cope with limb loss, including as a result of military service. I continue to support research into healthcare and social inclusion, which considers broadly how specific groups of people access health and support services. My book chapter centres on Harry Parker's semi-autobiographical novel, Anatomy of a Soldier, and explores medical and military transitions, as the main character transitions from able-bodied to amputee and from soldier to veteran as a result of his injuries, which are sustained while serving in the military. Existing academic inquiry into limb loss has concentrated mostly on the practical aspects of limb loss and recovery. I wanted to move the discussion beyond the etiology of limb loss and the practical aspects of recovery to focus on the embodied, personal, and sociocultural experience of losing a limb as presented in Parker's novel, and investigate how the main character, as an individual and as part of family and social groups, comes to terms with his limb loss and the subsequent gain of a prosthetic. This is explored within the context of transition from the military back into civilian society, and the novel delves into the impact this has on one individual's recovery, rehabilitation, and navigation of identities as they come to terms with these transitional life experiences. I am interested in the multiple identities that one individual navigates throughout life, and how an experience such as limb loss can complicate, challenge, and change these identities. Furthermore, how does an individual begin to make sense of and make meaning out of new identities, out of their own medical experiences, and take ownership of new identities which are sometimes thrust upon them? These thoughts and questions are central to my book chapter discussion. To describe the embodied experience of losing a limb and gaining a prosthetic, the novel is written from the narrative perspectives of the inanimate objects that assist Parker's character either in his military career or as part of his medical care, recovery, and rehabilitation. Imbuing medical instruments with a narrative voice humanizes medical and clinical procedures, which necessitates a suspension of the self for the character and distances him from his social groups. This allows for discussion of the ways in which the character's injured body is quite literally objectified. His bodily identity is reconstructed after his accident through the medical technologies used to physically put his body back together. This need for the reconstruction of the self, and the physical self in the novel, mirrors that of the need for the reconstruction of the character's individual sense of self and civilian social identity. I also explore how this loss and gain impacts upon an individual's sociocultural identity. I consider how, in Parker's novel, interactions with others outside the family unit are important for the amputee veteran's developing sense of self as an amputee and for the acceptance of their limb loss. The amputee must cope with social stigma, conflicting attitudes on limb loss, and mixed expectations of what an amputee's social status should be. Parker's character is forced to define his new normal life, or his new normal for life as an amputee, sometimes in conflict with narrowly defined sociocultural norms, and this is experienced against the backdrop of military to civilian transition, a process which also involves symbolic losses and gains in the individual's life. For example, the loss of military belonging and camaraderie, and loss of rank and status. On the other hand, individuals can also experience positives, such as freedom to express themselves as an individual and separate themselves from what can be an all-consuming military identity. This chapter presents an alternative medical discourse to put a humanistic rather than scientific focus on the medical experience, whilst exploring the ways in which an individual comes to terms with how normal life changes as a result of accident, illness, or disease, and thus each individual must redefine what normal means to them to cope with the long-term effects and changes. Thank you for listening.
Thank you. We'll hear next from Kamna Balhara, who is Assistant Professor and Assistant Residency Program Director in Emergency Medicine at Johns Hopkins University School of Medicine.
Thank you. To echo everyone, I'm very excited to be a part of this volume and to have this opportunity to share this with you all. So for me, my focus was on the electronic health record. So, among the many technological upheavals that medicine has faced in the 21st century, the implementation of the electronic record, or the EHR, has generated significant conversation and controversy. And from a personal perspective, as a physician, I certainly am not a fan of what many clinicians describe as death by 1,000 clicks. The advent of any new technology is momentous, and some advances, have come to be emblematic of the physician. So thinking about Lennec's stethoscope, for instance, it's not just a tool in the doctor's bag, but a symbol of the profession itself. And the EHR in its turn has birthed a new and controversial archetype, the physician posed in front of the computer screen. The EHR gained increasing importance in the 80s and 90s, with near universal adoption taking off after 2009. And since then, it has inspired sort of a veritable deluge of essays and articles and conversation amongst clinicians, with common refrains, populating physician complaints about the EHR, erosion of the doctor-patient relationship, degradation of bedside skills, loss of autonomy. Some of these changes are emblematic of sort of the larger commodification of medicine, but in this chapter, I seek to argue that such changes are actually occurring from the inside out via the very structure and form of the EHR itself as a medium. I posit that the EHR is a technoscientific object, a key apparatus of biomedicalization, implicating not just the transformation of bodies via technoscientific advances, but also the transformation of identities. So the EHR as a medium is operating a similar change on physician identities as other advances are operating on patient identities. So Friedrich Hitler suggests that media determine our situation. And I argue in the same way that the EHR is a force that has fundamentally altered how physicians view themselves. So in order to study the adaptations and evolutions of culture in response to the gramophone, to film, to the typewriter, Kittler uses poetry and literature contemporary to those innovations. So similarly, I used commentaries and essays and narratives published by physicians in the New England Journal of Medicine and the Journal of the American Medical Association on the topic of the EHR to sort of dissect the EHR's perceived impact on physicians' self-perception. And as a physician, I sought to explore what we had to say about the EHR and in turn, what that said about us. And the major themes that emerged were that there is a perceived rupture in physician identity, sort of followed by a reconstitution with new identities. So the first sort of challenge to identity is to that of the physician as storyteller, with the EHR challenging how the physician listens to and transcribes the clinical encounter by circumscribing physicians to checkboxes and diagnosis codes and robbing them of control over content and style of the story that they're telling. But it's even changed the physicality of listening to and writing stories, now looking at screens instead of looking at the patient, or the sterile anonymity of the typed or even the dictated word, replacing the highly individual sort of handwritten scrawl of handwritten notes. But in response, physicians have sought other ways to engage with narrative, consider the advent of narrative medicine, for instance, and they're also taking on new identities as co-creators of patient narratives. So not the last word in the record, but actually working with patients to weave their narrative into the EHR with new initiatives like the VA's My Life, My Story initiative, as well as the recent advent of patient access to clinical notes. The sort of second identity that appears to be challenged here is the identity of the doctor as detective. And so in these texts, it appears that the EHR appears to dissolve the mystery of the physician encounter. It dulls the critical thinking of the diagnostician. It changes the ways in which detection occurs. It changes the faces and the spaces of detection. But just as physician identities are appearing to be evolving in response to the changes in the role of the storyteller, the identity of the physician diagnostician is evolving in the same way. So rather than allowing the automation or cognitive shortcuts of the EHR to supplant that internal process of critical thinking, physicians are talking about how externalizing the diagnostic process by using the EHR as sort of an external brain or searchable repository of data is actually something that's beneficial, or curbing maladaptive responses to the automation of the EHR by reconsidering how we teach trainees to use the EHR. And some of these texts exhort physicians to take back ownership of the medical record, making this technology work for them, and reframing the EHR as a partner in diagnosis, much as the same way, patients and other healthcare professionals and interprofessional staff are a part of that process. So the EHR is rendering physicians into a reflection of technology with a subsequent dissolution of previously established identities. And there's a sense of loss pervasive in many of these texts, but there's also sort of a faintly optimistic acquiescence to the promise and possibility of the EHR. So just in the same ways that patients are gaining new illness identities via technoscientific advances, physicians are also replacing previous identities with new ones. Kind of propelling them into the era of biomedicalization by forcing the adoption of these new identities and perhaps creating a situation where there's a heightened symbiosis between physician, patient, and technology.
Thank you. We'll hear next from Joshua Franklin, medical anthropologist and psychiatry resident at the University of Pennsylvania.
Hi, it's wonderful to be here, and I'm really grateful for the opportunity to participate in this project and this book and hear from all the other authors. My chapter is titled Mixed Feedback, the Promise of Structural Competency Education. And it's a critical approach to structural competency, which is a concept developed by Jonathan Metzl, Helena Hansen, defined as the trained ability to discern the effects of structural processes on downstream health outcomes. In my field of medical anthropology and the interface between medical anthropology and clinical medicine, structural competency has ascended to a position of real prominence in terms of an organizing framework for the intervention of the social sciences into medical practice, especially within pedagogical spaces. So much so that in some places, for instance, my own institution, it's essentially taken for granted as the organizing framework for such efforts. And so my essay is an attempt to look at structural competency in a critical way, but not necessarily from the standpoint of looking at the genesis of the ideas and the things in an abstract sense that they leave out, but from a personal perspective. So as a physician resident and anthropologist, I'm thinking about my own experience moving back and forth between these two worlds that Rishi alluded to in the introduction to the volume, and his discussion in the introduction to the volume about culture and medicine. And the promise of this overlap is great, but the challenges of it are also great. And so I began with a vignette from my own clinical training, where I really acutely felt the disjuncture between cultural ways of looking at the healthcare space and the kinds of ways that we're trained in clinical medicine to look at it. And then I turned to a personal reflection on a specific instance of trying to implement structural competency in a pedagogical setting, which is a course called Doctoring at my institution, which is there's an introduction to medicine and society for first-year medical students, and medical anthropologists are brought into this course as supposed subject experts to sort of impart the wisdom of the social sciences and humanities in a setting where medical students can really benefit from it. And despite what I see as the desperate need for this kind of education, and I think that many in the social sciences and humanities, the medical humanities would agree, in practice, this course and its implementation became extremely contentious. And it raised really strong emotions. People objected to parts of the course content. People objected to things that were omitted. People were sort of overwhelmed with feelings that this course content was supposed to, was bringing up and challenging them. And this is at the very beginning of medical school. So the essay is an attempt to think through what that means in a space where structural competency as an intervention is a conceptual vehicle for providing this knowledge and wisdom from the health humanities and from social sciences to clinical medicine that is so desperately needed. And students are clamoring for it. And when it's put into practice, it becomes an emotionally very charged space, both for the educators and the students. What is happening there? And so in the end, I theorize it using Robin Reigun's work from object lessons and her idea of field imaginary, which he borrows from Donald Pease and theorizes in a feminist analysis as the sort of field's hopes and dreams for itself. And I think about what are the hopes and dreams that structural competency has for itself, and sort of end on an argument that in doing this work and entering these spaces at the intersection of medicine and culture, health and culture, social sciences and clinical medicine, we need to attend not only to the structural analyses and the concepts and the tools and the analyses, but also to the feelings and subjectivities that are produced and shaped and transit through these spaces. Thank you.
Thank you. We'll hear next from Gabi Shapson, who's Assistant Professor of Design Studies at York University.
Thanks, Arden. So my chapter in culture medicine is based off of my dissertation work, which I completed in June 2020 at University of California, San Diego, under the purview of Lisa Cartwright. The essay is a piece of visual STS, which is to say that it takes as a basic tenet that the graphic tools used in and coming out of science and medicine deserve just as much interrogation as any other output that science and technology studies might interrogate. In my case, I was inspired by my own experiences with chronic pain to ask about the graphic tools used to quantify and communicate that pain between patient and practitioner. The larger project looks at quite a wide range of graphic pain scales, but this particular chapter traces the origins, production, and use of something called the visual analog scale, which is one of, if not the most popular graphic scale used for pain studies today. The tool is quite simple. It's a 10-centimeter line with two labels, no pain on one side and worst pain imaginable on the other. And the idea is that the patient or study subject marks the line between those two poles to provide a seemingly qualitative response to the question of how much pain they're experiencing. That answer is quickly quantified, however, as the distance between the leftmost point of the line and the mark is measured. For instance, if the mark is 7.4 centimeters from the left, then the pain is given a 7.4 out of 10. When I first encountered the VAS, I didn't think there really would be much to it. It is, after all, just a simple line. But as I repeatedly tell my students these days, it's never just a line. By tracing citations in medical journals, I was able to go back to the line's origins. In the early 1920s, a company called Scott Company Engineers and Consultants in Industrial Personnel of Philadelphia, which is basically a mouthful for what we would have called a management consulting company today. They implemented a tool called the graphic rating scale, which is basically a visual analog scale, but with some interval points along the line also labeled. The GRS was given to foremen to evaluate factory workers, teachers to evaluate students, so forth and so on. And the idea was similar. An evaluator could quickly and efficiently measure their subordinates without the burden of needing to assign them numbers. So they would use the spatial relationships defined by the line and its labels to do so. The quantifying would come later once measurements could be taken and calculations could be made. The line goes through some changes and iterations over the next few decades, and eventually the labels between the poles are dropped. And by the middle of the century, the line's use has jumped from industrial to behavioral psychology and is eventually picked up by two pain psychologists in the UK in the 1960s. So the piece itself, the chapter delves into the history of the Scott Company, the printing technology used for the line's reproduction and proliferation, but also what it might mean to the in-pain subject being evaluated, that the graphic tool was originally meant for a supervisor-subordinate relationship. So I do hope you have a chance to read it, and I think I'll leave it there.
Thank you. It is a wonderful chapter, as are they all, but I hope you all read it. Okay, our next speaker will be Travis Chi-Wing Lau, who is Assistant Professor of English at Kenyon University.
Hi, everyone. It's so lovely to be here. I just wanted to say thank you again to Arden and Rishi for ushering us through the publication process, which was in many ways quite fraught during a very fraught period for all of us, and to Bloomsbury for believing in the project and coming to the rescue. So rather than talk about the content of my piece, I'm going to talk about what was actually not represented in the piece and sort of the conditions of writing. To be very frank, I wrote the piece when I was a postdoc at UT Austin, and I wrote the piece with the sense that I was not sure if I would remain in the profession because I had no idea how the outcome of the job market would go. So it was one of those pieces that if I said to myself, if I wasn't going to remain in the profession, what more would I like to say about the fields that I've attempted to intervene in? So in many ways, the piece is pervaded by this kind of haunting feeling of uncertainty about sort of the future of the very profession I'm in and my role in it. But also reading it back now in its published form, what I also noticed was just the delay in the way that publication works, where my ideas and thinking have changed since then. But ultimately, this piece came from a piece I wrote for Synapses called Taking Stock, which attempted to put disability studies and the health humanities in dialogue with one another sort of methodologically. And I wanted to sort out a question I had gotten a lot in my sort of interview work and sort of experiences talking to folks who don't work in the fields that I do, sort of like, what is it that I do methodologically? And I try to sort of work that out in this piece, which ultimately became the chapter. And it emerged partially too out of this kind of running joke in the field of health humanities that endlessly we get essays that attempt to define the field, but then talk about how it is impossible to define said field. And I kind of wanted to run with that as a kind of challenge, but also a kind of ethical impetus to define for myself why it is I do what I do, and why it is that I want to continue teaching students to do that particular thing. And to that end, I think at the heart of this piece is a sort of critical tension that I've experienced in my own work, in my teaching, and in my understanding of these fields is, in some ways, disability studies and the interventions that disability studies has made over the years since really its activist origins, it is very much at odds with the medical and health humanities, especially as they are housed in medical schools, right? What does it mean to be critical of medicine when so many of these programs are being funded by and housed in medical context, right? And as a colleague once said to me, sort of colloquially, how does a field bite the hand that feeds them? And I've been really sort of haunted by that observation about how is it that we can sort of posit very important criticisms and critiques of the theory and practice of medicine while also be funded by and enabled by those very centers themselves. And I gesture to some possibilities for thinking about CRIP futures for the health humanities. But I think if I were to sort of reflect on that moment of my writing, I wanted very much to sort of reconcile the tensions between these fields. But over time, I think the truth is that I actually want to preserve those tensions. And I think disability studies as folding into the health humanities has significant risks in the sense that it dilutes some of those critiques and their, I think, very blunt and necessary pushback to the problems of medicalization and what folks in disability studies would call the medical model. And I ultimately, I think if I were to sort of end my reflections, I would say that as we move forward as a field, as much as we're trying to define what it is we do in the health humanities, I think something that has been really important to me has been to preserve disciplinary difference in ways that can create productive tensions rather than trying to sort of smooth them out entirely. Those tensions can actually be really methodologically useful for us and legitimize the very specific disciplinary expertises that shape the health humanities. Something that I maybe got a little bit in trouble for a comment that I made in one of my essays for Synapses is sort of my not so much distrust, but discomfort with the language of plurality that's used in the health humanities, right? Let's have a bunch of voices and throw them all into the same place, and magically it's going to resolve itself into some sort of coherent methodology. I think that is a sort of too easy flattening of what is actually a much more complicated problem that I think Joshua was gesturing to in his remarks, right? That sometimes those tensions are exactly where we need to put pressure and actually work through in ways that don't necessarily resolve in some sort of cleanness that I think the field aspires to in sort of strange ways. So my hope in this chapter is to sort of think a little bit more about the possibilities of those tensions, and something that as disability studies becomes increasingly instantiated in departments as quote unquote a legitimate field, that we don't lose sight of some of those critical tensions. So I think I'll leave it there.
Thank you. We'll hear now from John Carranza, who's postdoctoral fellow at the Institute for Historical Studies at the University of Texas at Austin.
Hi, it's so nice to meet everyone, to see everyone. I'm happy to be here. I'm happy to have participated in bringing together all of our ideas for this volume, and happy to finally see it out in the world. So yes, I am a historian, and the way I approached my piece, Tales of the City as Historical Document, was I looked at the Tales of the City series by Armistead Maupin as a sort of historical document, and what it could tell us about the past. I came to this in part because I'm a historian of sexuality, specifically sex education. So I also listen to a lot of sources today, like podcasts. So I was listening to Dan Savage's podcast, and he recommended the series to a caller. So I decided to give the series a read myself. And what I found when I finally went and got a copy and picked it up was that it was a pretty lighthearted and quirky story about a core group of characters living in San Francisco. The storylines themselves were entertaining, but what was fascinating to me as a historian was how many references to events in the 1970s and 1980s informed the plots surrounding the characters, and how their reactions to some of them seemed as natural and quotidian in the way that we experience these major events that are eventually going to be written in history books later. So to us, they seem pretty normal and sort of run-of-the-mill, but eventually they probably have a larger impact that we don't yet realize. When I read more about Armistead Maupin in the series, I found that most of the situations were based on his own encounters in San Francisco during this period in the 70s and 80s, and were originally written as installments in the local newspaper. This made more sense to me as a historian who is, of course, very interested in the archives. That's primarily how we do our work. And who is also interested in how the past has been documented. So I began to think about how the Tales of the City series might act as a contained, portable archive of 2 decades of American history that gives some insight into the queer experience, especially as it related to the anti-gay crusades of Anita Bryant and the emergence of the AIDS epidemic. What struck me even more about when I see the AIDS epidemic emerge and the series was how from one novel to the next, it just sort of appeared all of a sudden. It didn't happen necessarily like that in real life, but for someone who was coming across these novels for the first time, it went from one book to the next, and all of a sudden there is a loss of a main character that I personally had become pretty invested in. So it was pretty sad. And it made reading about these characters a little more devastating. So I found that relationship between a long series or over a period of time becoming invested in characters and sort of following their lives and growing along with them. By reading the Tales series as a historical document during the AIDS epidemic, it shows in some ways the firsthand frustration that many people felt with having little to no power to get a lot of the finances or government to notice the impact that it was having on the gay community. In my essay, what I ultimately hoped to do was to show that novels, especially those in the serial format, do a lot to show us what a specific period looked like, mostly through the rapid production of story and by utilizing a lot of the author's personal experiences to inform the trajectory of the characters' lives. By developing rapport with the cast of characters, there is more at stake and more opportunity to understand how responses to disease and dying can vary from person to person. It can also give us some insight for how we might handle new and emerging diseases and epidemics and pandemics like we just went through, or still are going through, excuse me. And for me, also viewing these novels as a form of historical document and archive, it is important to sort of see this continuation and its persistence through time as being invaluable to adding to queer history and how we continue to conceptualize it.
Thank you. We'll hear now from Benjamin Gagnon-Chény, who is a physical therapist and a postdoctoral fellow in medical humanities HEALS program at Dalhousie University, as well as visiting scholar at the Institute for Comparative Literature and Society at Columbia.
Thank you so much. Can you hear me well? Yes? All right. First of all, like everybody else, I would like to thank Arden and Rishi, who created Synapsis in 2017, which I was very, very fortunate to join as a regular writer right at the beginning of my PhD in literature. And I'm super grateful to them for their hard work to make this collection book a reality, despite many obstacles in the recent years, as Travis said. I'm really honored also to be part of it with so many other compelling and engaged scholars with whom I hope to continue collaborating. As Arden said, to introduce me, I am a physiotherapist who branched off towards literature after several years practicing in hospitals in intense and acute care, as well as in rehabilitation. And as a young clinician, I came to literature not only by choice, but also because at the time I was battling severe depression. As I got to realize later in my career, burnout is affecting an astonishing number of caregivers from all fields, not only in hospitals, but also among the people caring, sometimes invisibly, for close ones struggling with illness. It was in this context of suffering and distress that I found in literature something like a sensitive companion, a real presence that didn't necessarily answer the many anguishing questions I had at the time, but that gave me a sense of relationality anchored in the infinite possibilities of sensations, languages, and imaginations. Literature opened the burned out caregiver I was to a feeling of community, coming to life through shared vulnerability, as we said sooner with Rishi. During my undergrad years in literature, I discovered the works of Hervé Guibert, a French writer who maybe you know. He's also a photographer and a journalist who died HIV+ at age 36 in 1991, during the apex of AIDS crisis in the Western world. I was struck by his powerful writings on his experience of AIDS, starting with his famous novel, To the Friend Who Did Not Save My Life, and its sequel, The Compassion Protocol, but also the uncompromising way Guibert has of making his own body, in all its possible states, the concrete material of his creation. In his first published text in 1977, long before he was diagnosed with HIV, Guibert wrote, and I quote, "My body is a laboratory that I offer as an exhibition, the sole actor, the sole instrument of my organic desires, partitions on a fabric of flesh, of insanity, of pain. Observe how it operates, harvest its performance." End of quote. For Guibert, literature is not an abstract narrative made of words, but an embodied art form to be experienced, felt, and shared. A quote from Guibert synthesizing this mindset was in fact the starting point of my chapter for this collection that is entitled The Suffering Caregiver. At the end of both his personal diary and his life, Guibert asks this provocative question, and I quote, "Is the experience of pain preferable to the annihilation of experience?" End quote. This question resounds from the darkest areas of Guibert's terminal phase and asks whether pain would be the touchstone to a fully embracing death as a crucial life experience and not as a dreadful moment to abolish in over-medicalization. Through my research, I found that Guibert's question was reaching to the heart of contemporary debates over physician-assisted dying, which is legal in Canada since 2016, which consider the patient's experience of intolerable and irreversible pain and suffering to be the ticket to this ultimate care, that of a chosen and dignified death. As medical and legal discourses dominate physician-assisted death, it appears that many physician caregivers working in end-of-life care find the task difficult and disturbing. A research from Dutch sociologist Roland Pesman suggested that evaluating end-of-life suffering is at times so intricate that physicians cannot even imagine the word is eloquent, imagine the complexity of unbearable suffering. Throughout the chapter and rooting my reflection in Guibert's literary works, as well as in seminal essays by Freud, Georges Canguilhem, Michel Foucault, David G. Rothman, Hélène Scarry, and Emmanuel Levinas, I plead to free our cultural relations to suffering, disease, and death from the confining walls of hospitals, as well as from the blinders of evidence-based discourses and ethical norms. Borrowing some of Guibert's final words, I argue, that one of the roles of literature is to teach death, and that through its aesthetic sensitivity, even often anchored in equivocal feelings of ambiguity, we could do more than debate on the place of death in our cultural life, but also advance, even when the path is dark or disturbing, toward an embodied experience of end-of-life pain through literature. I plead that it is only at that price and at that risk that we may better humanize the end of life. Thank you.
Thank you. We'll hear now from Diana Rose Newby, a lecturer in writing at Princeton University.
Thank you. I want to start by echoing everyone's thanks to Arden and Rishi, and to also thank my fellow contributors and panelists. As I prepared notes for this précis, I was very tempted to simply read the chapter overview that Arden and Rishi wrote in the book itself, as it summarizes the piece and its contributions much better than I'm probably going to, but I'll do my best. Some of you may have read Confessions of the Fox, and if you have, you will appreciate the difficulty I tend to experience when I try to describe this book. Part memoir, part historical fiction, part speculative fiction, drug novel, campus novel, criminal confession, and carceral critique. Rosenberg's 2018 novel is generically multiple, to say the least. And it's plural structurally as well, making creative use of the literary technique of narrative framing, whereby the novel's central story, an early 18th century tale of jailbreaking, gender bending, and wild sex having, becomes contiguous with the exploits of a beleaguered 21st century academic, simultaneously battling his university's culture of surveillance and trying really hard to get laid. All of this formal multiplicity, as I argue in the chapter, works to mirror and reinforce the novel's thematic investment in plurality. Plurality that is, as described, an embodied resistance to the social and biomedical maintenance of sexual difference. And I'm kind of cracking up and feeling self-conscious speaking in the wake of Travis's comments about plurality. Maybe we can think together, Travis, about whether it's a productive exploration of plurality that I'm offering in this chapter. To explain what I'm getting at here, just a few more words about the novel's plot. The central story of Confessions is a fictional retelling of the life of a real historical person, a thief and a sort of Robin Hood figure named Jack Sheppard, whose literary stardom following his public execution was cemented in a number of popular plays and in a supposed work of autobiography that has been attributed to Daniel Defoe. Playing on the latter, Rosenberg presents the central story of Confessions as though it might be Sheppard's real autobiography, and he fashions Sheppard as a transgender intersex man. I argue in the chapter that reimagining Sheppard's identity in this way enables Rosenberg to perform an extended critique of endocrinology's history of violence in service of a reductive binary narrative of gender and sex. Sheppard uncovers a plot wherein London's penal system has been harvesting the sex organs of incarcerated men in order to manufacture and sell a so-called serum that is effectively a form of exogenous testosterone. This grotesque conspiracy is motivated by the belief that an ideal form of masculinity is materially discoverable in the bodies of the world's most famous rogues, an assumption embedded in a long tradition of biopolitical brutality working to establish sex dualism as a social and medical fact. And here I'll note that I'm thinking in conversation with Katrina Karkazis and Rebecca Jordan-Young's work in their book Testosterone, an Unauthorized Biography, which provides an illuminating investigation into the history of endocrinology, and much like Confessions, shows how the work of this field has long been hitched to a social myth-making machine driven by a biologically determinist understanding of gender and sex. But what I particularly want to emphasize about Confessions of the Fox is not only how it critiques endocrinology, but also the forms of resistance that it envisions. Against dualistic models, Rosenberg presents multiplicity, a way of thinking about and inhabiting embodiment as many, as irreducible to the single or the self-contained. This way of thinking emerges partly out of how Rosenberg specifically theorizes trans and intersex bodies as himself a trans writer, but it's also a paradigm that he more generally extends to all forms of embodiment, both human and otherwise. Throughout this novel, bodies of all kinds repeatedly break down and are remade. They are opened up and they are penetrated, they are divided, they are combined, they are blended and transformed. Inevitably, I argue, Rosenberg is helping us see how living bodies in general tend to exceed the strictures of biomedical frameworks that take not only sex dualism, but other similarly restrictive precepts as their premises. I've been speaking at length about bodies, but to conclude, I'll circle back to where I began regarding issues of literary form. As my chapter works to show, Rosenberg's rendering of plural embodiment finds material echoes in the novel's compound structure and its blending of generic modes, literary techniques that I think are partly just playful, but that can also be interpreted as forms of critique and resistance in their own right. In calling attention to its own status as thoroughly plural, Confessions of the Fox not only eschews literary definition, but also invites us to think of all novels as inherently heterogeneous against certain practices of academic insistence on the single and the singular and the hierarchical. In this way, I think Rosenberg's novel emblematizes a growing body of speculative historical fiction attentive to how generic blending can push back on reductive reading practices and the violence of the canonical archive. And so too does Confessions share affinities with what I think is the particular practice of health humanities scholarship, bringing together the contributors to this volume, a practice that understands bodies, and I think I'm paraphrasing Arden here, as created through language. And a practice that thinks ethically and imaginatively about new ways of enacting that linguistic creativity.
Thank you. We'll hear now from Anna Fenton Hathaway, the managing editor of the journal Literature and Medicine and instructor in the medical school at Northwestern University.
I too want to echo everybody. And also I think my chapter might speak to Diana's the way Diana is speaking to Travis's. So I look forward to our conversation afterwards. This chapter grew out of my interest in how literary or textual form shapes the experience of reading and how that experience might show up in our lives or our decision-making. The essay, I was responding to suggestions that we start putting dystopia fictions on bioethics syllabuses, and even that dystopias might sharpen policy debates about healthcare. While some of these suggestions are persuasive, and I'm happy to point you all to their sources, I wanted to raise some objections we might consider before the health humanities goes all in for dystopia. Okay, so here's the argument. The intended effect of dystopia fictions is to spur readers to action via a jolting fear appeal. In the 2020s, that effect became seriously blunted. I propose a few explanations for the short-circuiting of the fear appeal, although not perhaps the ones you might be thinking. I trace that blunting to the overuse and misuse of dystopic tropes in American political rhetoric, as well as the rise of a journalistic kind of tick in editorials and public talks by physicians. In the chapter, I have a few examples of this approach, but it's essentially a kind of garishly terrible description of a scene or a system, followed by the familiar reveal, this is actually happening today. This last use of dystopia, which Rob McAleer calls redescription, stood out to me because it echoed a trend that I was seeing in my own seminars for medical students on speculative fiction and bioethics. Instead of encountering dystopic scenarios as alarming or motivating or at all revelatory, my classes were often just trying to crack the case. What does this correspond to? This was most memorable when we watched a Black Mirror episode called Men Against Fire, which features the use of perception-altering technology to dehumanize targeted populations and make it easier for soldiers to kill. In the essay, I describe how when one student linked their episode to the use of Facebook to dehumanize the Rohingya in Myanmar, we left off any further discussion of the malleability of otherness, the willingness to harm, or the provocative end of the episode. And obviously, I could have pointed us back to any of those topics as the instructor, but I was doing the same thing. I was on the same kind of hunt for reference. I was trying to figure out which war it was that had given rise to the failure to fire hypothesis, who had coined it. And interestingly, when we were preparing our manuscripts for publication, our fabulous copy editor, Molly Lindbergh, also pointed out another historical reference, which I include in a footnote. So as I was thinking about what these hunts for dystopia reference do to readers, how they direct attention laterally or retrospectively, I was also searching for texts or moments that did prompt rethinking, that did give that jolt. And I ended up including one counterpoint in the essay. It's a scene from How to Die in Oregon, a documentary about medically assisted dying, where a man who is not pursuing this type of death demands to know why an insurance company will cover his euthanasia, but not his chemotherapy. The way he viewed the world made me revisit how I had read all the previous scenes and the difference between him and the rest of the figures in the documentary, who were all depicted with adequate or even ample resources with loving families and supportive physicians by their side, was one reason for my chapter's title. So the questions I didn't answer in the essay are still with me. And the most fundamental one is, what can any text or genre make us do? And the other is about dystopia in particular. And I'm still trying to figure out if there's something about its internal form or generic conventions that elicit the response I'm describing. Is it something about where it positions the reader, any reader? Or is this blunted response just a response to a historical moment, a medical, cultural, historical peak dystopia?
Thank you. And then our last writer in the volume is Roanne Cantor, Assistant Professor of English at Stanford University.
So thank you for having me as part of this. I had a way easier job than everybody else because I just wrote a coda. So I read everybody's pieces. And of course, many of us had been working as a community of scholars together for many years. So there was an existing coherence in the pieces. And all I had to do was like sort of thread it together cutely, tie a little bow and be like, ta-da! So I'm going to do the same thing today. I'll go over a little bit of my insights, and then I'll also kind of pull out, as some of you have done, what I didn't write and maybe how I would have written it now, thinking about the moment that we're in as the book is coming out. And so listening again to these synopses of the arguments that were made and sort of having it jogged in my memory, I was thinking about the different temporalities that we're inhabiting, and the way that temporality is one way of thinking of medicine and the humanities, and especially disability studies, which is an area that originally brought me into this field. And so I'll reflect also on a little bit of my experience, which is that I proposed a class on disability studies back when I was still a visiting assistant professor. And I expected that I would have a lot of students who were interested in the sort of like, critical disability angles that interested me and had brought me into that arena. And then I got into the first day of class and I went around the room and I realized that all of my students were pre-med or pre-health. And that their approach, somebody used ambivalently the word, Rishi, I think this was you, applied humanities, and we don't know if this is something that we want or not, right? And so I found myself in real time trying to solve the problem was, am I prepared to do applied humanities? Because it seems like I'm doing applied humanities. And I do that to this day. And interestingly, in my own experience, increasingly I have students who are coming into the same class because they are working through their own identification with disability, as opposed to merely thinking about serving disabled populations. But I have a real softness in my heart for both of these populations, and how they approach literature and how they approach these questions quite differently. So the four temporalities that I'm thinking about are the already, the not yet, the chronic, and the urgent, right? So many of the pieces that we heard about today are thinking about the already. What do we already know? What is the history of the medicalization of the body, and how does humanities register that history in each of its moments of emergence? So thinking about how it is registered in Shakespeare, how it is registered in the Victorian period, and then how it emerges, sometimes reflected on these earlier periods in the present. And then also thinking about the not yet, the idea that we just heard about in terms of speculative fiction and what it does or does not open for us in terms of thinking about an embodied future and the role of medicine and health in imagining that future, right? But already and not yet are also positionalities for the potential readers of this book. And I think also for the students that we interact with, both in the creation of these texts and then, gosh, we hope, in the reading of these texts in the afterlife of the book, if it does have one, right? The already of the student who comes to us from the identity position of somebody who has been medicalized, who is disabled, who is thinking about these things, and who already has a lot of critiques, right, of the systems that they're entering. And then not yet the student who has never been exposed to those things and for whom one of the classes in which they might encounter these materials would be the first moment, and a really important first moment. And how do we make space for both of those students, the student that, is impatient for us to get where they already are, and the student who's shocked and actually needs a little bit of time to be brought forward. And then the other thing that I was thinking of, sort of pulling off of Arden's opening remarks, was the idea of the chronic and the urgent, and how we might weave those into the fields themselves that we're trying to bring together, the humanities and medicine, right? And also especially the idea of chronicness and its potential relationship to defamiliarization. So those of us who are trained in literary studies, we think about defamiliarization as our bread and butter, that something that narrative can do and literature and the arts can do is pause us and make us think, right? And interrogate the assumptions that we have about how things are supposed to work. And in a certain way, I see this folded in with a certain line in disability studies that thinks about chronicness in terms of chronic illness and chronic pain, and its different temporalities. And usually that means a kind of like expanded or dilating temporality, and also a kind of unevenness in this. And one of the people who theorizes the chronic actually stops in the middle of an essay, and I think very rightly and intelligently says, like, well, gosh, I would hate to use this new form only to elevate the kind of avant-garde, difficult, tricky, winding narratives that we already always elevate, in literary study. How do we make the chronic sort of accessible in a certain sense? And this is where I sort of ended my essay, and what I'm still thinking about that's very special about this space, which is the need to balance the chronic with the urgent. At least two people in this Zoom room work in urgent care and emergency medicine. What does it mean that part of what we are imagining ourselves to do is be in a real conversation with medicine, where sometimes you just got to make a choice, right? And what a privilege I have as as a literary professor, that the choices that I make are slightly less imperative. They happen on a slower timeline, and I can linger with interpretation at a different rate. So just thinking about the way that we live in all of these temporalities at once, and we also live them unevenly, and what a special space it has been over the long temporality of publishing a book, right? To share with you the chronic and the urgent, the already and the not yet.
Thank you. A beautiful summing up of so many of the concerns of the chapters. At this point, we're going to open the Q&A to both the writers themselves, if you wish to ask questions of one another or pick up any of these threads, and to people attending in the audience. So if you have a question, please put it into the Q&A box, and I will hopefully select it. For now, I was wondering if any of the writers wanted to pick up any of these threads. Maybe while you're mulling on it, I'll just say how gratified I am to hear how people's thoughts have changed since they initially wrote the chapters. That has been extremely fascinating. I did not know that this was the direction our conversation would go tonight, but it's a revelation because it shows that the work that you did is so flexible and also deserving of scrutiny over time as well. So I'm very grateful to people who shared the questions that they wish that they had answered, or the questions that remain unanswered for them. That has been fascinating for me to encounter as the editor of the volume. Alicia, go ahead.
Yeah, thank you. I was really moved, Travis, by your summary of your article and how you envision tensions. And I wonder how you think about forming the spaces, right, that we can explore those tensions and respect those tensions and disciplines. Like, how do you imagine us coming together in space? Like, this is a good example here, right? But I'm thinking about, the classroom or conferences, right? And all of these discipline specific spaces that sort of divide us. And I just wondered if you were thinking at all or envisioning, right, this kind of, I won't say utopian, but, rearrangement maybe of what you were talking about in space and how we can come together and collaborate in the ways in which you were discussing.
It's really good to see you, Alicia. And I think you've asked a really urgent question that I think is the next step in what the piece was aspiring to, right? So if I'm identifying a problem, perhaps in the way that the health humanities is imagining itself and its vexed relationship to disability studies, I think the right question to ask back is, okay, so what do we do with that? If we're going to acknowledge tension, how do we sort of live with that tension rather than sort of dispel it? How do we sort of coexist with tension and hold it as a place of theorizing and doing some of this work? So I think my way of responding is to take very seriously, to me, what is the most important facet of Synapses, which is that other subtitle, which is a department without walls, right? So what does it mean to think about a space that actually wants to, in many ways, aspire to maybe the thinning or making permeable of these disciplinary or departmental walls? Of course, my argument is suggesting that there's some dangers to that, but I think the way that I would maybe nuance my own claim there is, what does it mean to make very visible, explicit, and what would it mean to foreground disciplinary tensions as the sort of foundation for any argument or intervention we want to make in the health humanities? And this might maybe sound strange, right? But part of me has been really moved by the decision a lot of scholars, particularly in our generation, that are making, that want to talk about positionality, about the conditions of the production of any type of argument, or the means by which we access any form of knowledge. What would it mean to start from that location and force confrontations, I think, across disciplinary differences? What would it mean, say, for in a conference on health humanities, to really think about tension and difference first, have that be actually the sort of grounding place we actually try to address a particular problem without trying to disavow it? And I think that's maybe an ethos of sort of scholarly work more than sort of a clear-cut intervention. But I've been really thinking about sort of this, what I think many of us in this room have experienced as a kind of lazy interdisciplinarity, where it's like, okay, here is a plurality of voices that then suddenly is going to amount to the coherence of a particular field, rather than us sitting with the fact that, yeah, our work in anthropology and literary studies, in comparative literature, in sociology, are in fact going to conflict. Our very terminological use of shared terms that we sort of use interchangeably are in fact not the same. Can we do a little bit more of that nuancing work that allows us to draw from our expertise more substantively, without saying that one discipline ought to be better than the other? And I think that was one of the dangers I was experiencing in reading my own chapter, where I was suggesting that disability studies is doing a sort of better form of critique than the health humanities. I think much the opposite, that they actually need to be in constant dialogue across tension rather than one over the other, if that makes sense. I probably didn't answer your question, but I'm trying to think out loud with you, Alicia. This is a really important question to me.
No, that's great. Thank you.
Alicia and Travis, I think it just speaks to the challenge, right, implicit in interdisciplinary work. I think it's hard. Interdisciplinarity implies a discipline. There has to be a discipline to be interdisciplinary about. And a discipline has within it a set of norms, procedures, forms of evidence, standards, some of which we sort of are frustrated by and kind of want to like tilt at, but others have produced tremendous amounts of knowledge and tremendous amounts of sort of positive benefit, right? Greatest benefit to mankind kind of work that we have to also acknowledge in a kind of generous form. I think that there is a kind of antagonistic, confrontational agon that's building, but then there is also an incredible generosity that has to occur when the humanist and the scientist or the social scientist are all meeting together. It's like they all walk into a bar kind of thing. There's just a joke there somewhere, but partly it's that they need to be kind of working in concert. And I think that's why sort of team taught classes and team taught essays are really important. I'm not sure that this is the work of an individual, right? This is the work of kind of individuals coming together and forming some sort of a collective. And that's why I think it just reassures me about the work that we've done here. A number of you said it, these aren't isolated essays that just sort of happen to come together and they were put into a volume as examples, excellent examples, perfect examples, great examples of medical health humanities work, but they're more than that. They clearly grew in relationship to each other, and I think you can hear the kind of recurrences and the voice and almost the conversation that builds across disciplines that you wouldn't be able to kind of build this kind of knowledge. And it speaks to, I think, and I'd love to hear what everybody else thinks about the kind of heterogeneity of the objects of study, because maybe there are methods that are somewhat similar, but the objects are quite all over the place, right? From prostheses to pain scales and the New England Journal of Medicine, popular films, memoirs, the electronic health record and technologies. So, what do we do with the heterogeneity of kind of medical object or medical artifact that allows us to think?
Yeah, I think one of the real beautiful things to me about writing for Synapsis was actually that my brother-in-law is in medical school, and you would think that we'd have nothing to talk about, but when I started writing for Synapsis, I started talking to him about, well, how do you treat like stillbirth, for example? I wrote a piece on stillbirth, or, I started finding out about like the flow charts. I got my hands on some medical texts, and it makes me think that sometimes this coming together can be quotidian, right? It can be everyday conversations, just being sort of open to what, is attention, right? Is difference, but also, working to see it different ways. So yeah, that was one of the really great things that happened to me as a writer for Synapsis, is we started having conversations, and he started informing my work.
Anna, do you have a thought?
Yeah, just a quick question. I love the temporalities kind of framework for understanding this. I think that's beautiful and helpful. And I was thinking about defamiliarization. I think, Arden, you mentioned that being kind of one of our threads across pieces. And I'm wondering about that temporality. And I wrote about that for Synapsis too, but I'm wondering how long defamiliarization lasts. Is it kind of surprising momentarily? And then that makes me think, I both want to turn it over to Gabi to hear about, did learning about that pain scale defamiliarize, is history where we need to go for this, or is technology and its accommodations or affordances or constraints? So I guess I would love to hear how long you think defamiliarization lasts, if it's a kind of worthy thing and where we should look for it.
It's a great question. Gabi, do you want to talk about the pain scale and how that changed for you?
Yeah, I can just briefly, I can say, there is something about, I saw, this is like a little tacky, but I saw a tweet today of a disability studies scholar who said, like, fellow disability studies scholars, is it heavy to write about disability studies all the time and be disabled? And writing the dissertation about pain scales and, sitting for a long time, which can be a really painful experience. And my son was born as I was finishing. And so there was a lot of physical my body was going through a lot. Obviously not what my wife went through, but like I was dealing with a lot of physical pain then, and so it was sort of like I'm really tired of talking and thinking about pain, and I live it every day. But at the same time, I now go into the physician's office and I see it on the wall and I say, hey, I know something about that. And I'm actually trying to get funding right now. I have funding for a small pilot project, but I just put in for a pretty larger grant to try to talk to practitioners and pain patients about what, if I were to tell you these stories about the pain scale, does that change your experience? What is your experience like using these things, and can I teach you about them, and how does that change? So it's a great question, one that I hope to answer over the next couple of years. But for me, I sort of nod and wink when I see it now on the wall.
And we had a question coming through the chat from Declan Gould, who responds to Dr. Cantor. Where does the idea that the avant-garde is inaccessible come from when we're talking about accessibility, or I guess inaccessibility? Are we talking about accessibility for the reader or the writer? Do you want to take that, Roanne? And other
Sure.
people
I think this is pretty this is coming from it's Friedman. I'm blanking on the name of the person, but I can actually sort of like try and pull up this essay after I answer my question, and I'll so it comes from this scholar who is a disability studies scholar at this point, and who is instrumental in the temporal turn in queer theory as well, right? So I think it is pretty standard to make a kind of tautological association between avant-garde, and here maybe what I want to say is sort of like modernist or something else, but between avant-garde and difficult. Like, that's not me, that's the world, right? Now, that's not always true, but I think that like the whole point of being avant-garde is that you are ahead of the general public, ahead of the zeitgeist, and therefore again, my putative, med school aspirer who maybe gets to read one book a year outside of my class, like just doesn't know what to make of. And so this also reflects like access in terms of what my students tell me is accessible. And when I teach literature that self-defines as avant-garde, or that I think of as avant-garde, for example, La Ciudad Ausente by Ricardo Piglia, which is like has really interesting resonance for disability theory and is about like the end of dictatorship in Argentina. My students hate it because it's way too weird for them, and it does have this sort of like chronicness where it's all jumbled. So like this is, maybe I should think about all the resonances of access, right? But I'm thinking about readers. What does accessibility mean for a writer? Meaning, like, are there ways in which writing out of order might actually be the clearest way for somebody to write? I think that's an argument that like Kathy Caruth might have made, these are arguments about how different body minds engage with the idea of time, and Sammy Shalk, that's the person I'm taking body minds from. So like, yeah, there may be ways in which certain kinds of representations of chronicness are actually easier to write for the person for whom it tracks onto a particular experience. I think if you look at writers, letters and stuff, though, for the most part, like a more belabored style is also harder to write. So like I think that's a tautology and we should interrogate it, but yes. Like,
Diana, I know you wrote chapters on speculative fiction. Do you have any thoughts on the avant-garde, or should we move to the next one? Oh, okay. All right, Ilaria asks, I think this is a question for Rishi and me, but anyone is welcome to weigh in. I'm wondering how you foresee this anthology impacting both clinical practice and medical education. Where do you hope what do you hope students will take away from this work? Also, were there any challenges you faced in editing the book and bringing together these diverse perspectives? Rishi, do you want to address any of these? And I have some thoughts as well.
Yeah, I'm trying to sort of think through. I mean, again, it goes back to that question of kind of application and utility. And do I imagine that these texts are kind of floating around in the clinic, right? I mean, I remember there was a physician who would kind of read poems during, medical rounds, and it wasn't clear kind of what the productive value of that is. So I'm going to maybe use Roanne's point about kind of temporality here, because I think one of the most important things that the kind of work in this text does is slow everybody down, and it changes the way we kind of approach clinical experience, which is the way like an engineer or kind of I think a clinician approaches something is as a problem. Perhaps not always good at defining what the problem is, but certainly knowing that there's a problem to be solved. And the works, I think, in the volume will kind of alter that perspective from a problem. It's a question of kind of redefining what is seen as a problem as something else, right? I mean, Canguilhem in The Normal and the Pathological talks about the continuity between the normal and the pathological. And I think that is really critical, that they aren't of a different kind of ontological state, that in fact, they're just about shifting norms, and the pathological is a totally normal situation. And in fact, much more likely the kind of normal situation of human beings, which I think speaks to, I think it was, if I forget it was John or Benjamin that was talking about suffering, right? Because kind of pathos is suffering. That's the one continuity that we can kind of have throughout all of these texts. So to me, it's a question of kind of slowing the work down, moving from a problem-based approach to something that not normalizes, but puts it in a kind of different context. Arden, did we have any challenges editing the book?
Our greatest challenge had to do with publisher issues during COVID-19, but I don't really think that that's of much like intellectual merit. Yeah, as far as actually putting together the chapters and working with all of the writers, it was just a huge joy. As you probably heard from the presentations, the chapters dovetailed with one another so well. And we didn't speak much about the organization of the volume, but you might have intuitively gleaned it, that we began with kind of a literary approach, and then we looked at medical practices, and then we looked at, I'm blanking on the third one. We looked, I think, at contingencies, situations that were difficult situations that could go in different directions, and then the chapters that were thematically connected, and then finally alternatives, which were in form of speculative fiction. So in terms of how to organize the volume, I think because people had been in such rich conversations throughout, the sequence of chapters, the thematic continuities between them, and the disciplinary approaches really were very pleasurable to work with. To go to Ilaria's question again, one thing I wanted to comment on, which was sort of the inverse of something that Rishi noted before. Rishi talked about the diversity of objects of study. And another phenomenon that I really appreciated in editing the book was the creative and unusual disciplinary approaches to objects of study for which we think we have a standard approach. So we think that the EHR is this medical tool in the province of medicine, but what happens when we look at it as a media product? Or we think that Tales of the City is a collection of fictions, but actually what happens when we look at it as a historical archive? And by turning the disciplinary lens on these objects that would seem to fit a familiar kind of interpretation, by turning the disciplinary lens on them, entirely new readings were yielded. So one thing I'm taking away from working on the volume with all of you is the value of shifting the lens through which we view the object of study, and how we can get quite different insights into it through that. And then it's as foreseeing impacting both clinical practice and medical education. I mean, we hope that it won't be a watershed volume changing the world. I do see different chapters will probably resonate differently with different readers, different student groups, or whether they're read in the clinic or whether they're read in higher education. But I do think all of them are written in a way that is accessible and interesting. And a reader could read all of them and really come away knowing more about each topic. So I commend the writers for their wonderful expression, as well as their wonderful choices of topics. Yeah, we're almost at time, actually. Rishi, do you have any final comments that you'd like to offer before we close the conversation? Oh, pardon me, I cannot hear you.
Maybe just a couple. The first one I think would be something like definitional, right? I think that comes up all the time, and people have brought it up. What is medical humanities? And I have 11 different definitions depending on kind of what the mood is, time of day, time of month. But I think the more important question I come away with from this volume is, this is the medical humanities, right? Like it's in these individual, very, very specific examples of the kind of work that's being done. That's the medical humanities. And I think that range is really, really important. The other piece that I think I kind of come away with this volume is that medical facts are not kind of natural species, but they're only intelligible in the context of institutions, technologies, kind of authority and worldviews. And that, I think the volume really strongly kind of suggests very powerfully. And that the approach that everyone has taken is, I would say, a kind of dialectical approach to the normal and the pathological, to illness and disease, to subjective embodied experience, and to abstract, generalized, objective categories. And I think that is what sort of drives this kind of the power of the volume in total. And I'm just, very thankful to be working with everybody here. It's just been an incredible experience.
All right, so I'd like to echo your thanks. And thank you to everybody who's attended and asked questions. We really appreciate your presence. And beyond everything, thank you so much to the authors of the chapters for fabulous work, stalwart perseverance in the face of adversity, and for your wonderful contributions tonight. This is like a dream for us to be able to feature all of you in conversation with one another. So thank you. And it's time to close now. So we're going to bid goodnight to everybody who's been attending.